Good afternoon, everyone. My name is Peter Guan, and I'm from CFPIC. Thank you all for joining our CalAIM Lunch and Learn. Our CalAIM Lunch and Learns are an ongoing series. Special thanks to the County Welfare Directors Association of California for their support. This webinar is recorded and will be posted on our CBSI webpage. The webpage link is in the chat. Today's topic is on the MCP Tribal Liaison, the training session we facilitated by Tara Gray and Jessica Mosher. They will help you understand the Tribal Liaison role, its connection to CalAIM, and key insights and emerging best practices from ongoing collaboration efforts. Tara is the MCP Tribal Liaison for BAIHP and KHS, dedicated to strengthening health access and equity for Native American communities, while Jessica is a public health leader dedicated to advancing the well-being of American Indian Alaska Native communities through culturally grounded policy, research, and advocacy. With that, I'll pass it on to the presenters.
Liaison Yavu, Ketchimalea. Again, my name is Dr. Jessica Mosier, and I'm joining you from the traditional lands of the Mwekmaloni out here in San Francisco, California. I'm a guest on these lands from the Pasco Yaqui tribe of Arizona. Tara's here. Do you want to go and introduce yourself?
Hi, good morning, everybody. My name is Tara Gray. I am from the Athabascan tribe from the village of Chitna in Alaska, and I'm the Managed Care Plan Tribal Liaison for Bakersfield American Indian Health Project and our Managed Care Plan with Kern Health Systems.
Thank you. So I'm going to go over our land acknowledgement that we share at our monthly CPI meetings. So we respectfully acknowledge the 110 California Native American tribes and the 80 unrecognized, all sovereign. We pay homage to them in this collaborative, an important step towards healing the past and co-creating the future through continued partnerships to improve our community's health and well-being. So for today's meeting, we did the welcome. We're going to go over what it looks like to have AIAN culturally responsive engagement in the context of their communities. Tara is going to review the APL 24-002, which is the MCP Tribal Liaison role. And I'll be going over the CalAIM overview and also traditional healers and natural helpers. And then we'll wrap up with a discussion, questions, and then any other additional items we want to cover. So by the end of the session, you should be able to know and clarify the tribal liaison responsibilities, as well as define role within CalAIM implementation. So just to level set, this is, of course, a map of California. It shows the 109 federally recognized tribes in California, and the 80 recognized are not displayed, the ones that are unrecognized. On this map, there are 9 urban Indian organizations, and it kind of goes over the geographically diverse and rural access challenges. As you can see, there's at the top of California, which we kind of call Lower Oregon because it looks the same, where the redwoods are, and a lot more distance between being able to receive services and where people live versus the more urban areas where there's urban clinics within a couple miles. So that's the bigger landscape of it all. So I'll take a minute and go over what kind of our historical trauma is kind of like a high-level overview, and then our unique healthcare practices in American Indian Alaska Native communities, as well as what it looks like today, so the current urban and rural perspective. So historical trauma. This is a lot of history here, but we'll just kind of go over the basic high level. So we suffered from forced assimilation through boarding schools, where we were kidnapped from our families and taken away to be indoctrinated in different scenarios, but where we weren't allowed to speak our language, practice any of our cultural practices, just basically a way to integrate us into community, as they thought. And because of that, there's an ongoing mistrust of the healthcare system overall. Also, we had a very violent colonization and displacement. I'm not sure if you're aware, but more than The estimations around 80 to 90% of our population was uh, murdered or suffered from diseases that were brought over from the colonizers. So that really created an intergenerational health inequities. Also, we are part of a chronically underfunded health system called Indian Health Services, which is always doesn't keep up with the current needs of the different levels of health care, and being able to compensate it at a way to be able to keep their doors open. It seems like we're doing the best we can with what we have, really, which causes persistent poor health outcomes. We also have the intergenerational impacts of the abuse of boarding schools. So when you take someone from their home and raise them without a mother and father, when they become mothers and fathers themselves, they don't really understand how to be in that role. And so it's really worsened the mental health and trauma symptoms of our people. Also, there's racism in the healthcare system, unfortunately. I've heard that doctors say, "Oh, I really shouldn't spend my time explaining this to the patient because they won't understand it, so why try?" Or they're mistreated entirely or ignored, which results in a lower utilization of mental health services. So that's kind of the unfortunate overview of our trauma in relation to the healthcare system. So we do have our own version of our own unique healthcare practices that are kind of the center of our community. So we have traditional healing methods. We rely a lot on herbal medicine, what we can find around us, as well as spiritual healing. We do a lot of drumming. That's a way of kind of connecting ourselves to the beat of the drum, our heartbeat. Storytelling, which is pivotal to being able to maintain our narratives. As well as balance-centered wellness approaches. So always being in balance, the negative versus the positive energies, or there's different approaches to how to maintain that balance. Also, the medicine wheel. You often see that four-colored disc. That's something that you have to maintain balance in all four of the directions: north, south, east, west. Then the tribal doctors and traditional healers. So we provide culturally rooted care, including healing hands or massage, just the laying on of hands in general. We also have plant medicines, cleansing rituals, and we rely heavily on prayer. Usually we start each of our meetings, we call it in a good way, in connecting with Creator in prayer. It's a non-denominational prayer. It's really to the higher power that we call Creator. We also have cultural wellness practices such as talking circles, smudging, which is the lighting of to be able to generate smoke from sage, and kind of bathing ourselves in that smoke and cleansing our spirits, and sweat lodges and that provide emotional support. There's usually a story, a certain prescribed method to having a sweat lodge, and to bring about healing, really. We also have a very spiritual way that we walk this earth, and our own behavioral health. So one behavioral health practice that you may not be aware of is like when we're in mourning, we cut our hair to symbolize the ending of our time with someone who has crossed over. So the hair represents like a timeline, and that timeline has ended with the individual. So we cut our hair and show that we're in mourning. So as a visual to other community members, they'll say, "Oh, that person's in mourning. You need to treat them differently. Reach out. They're really see how they can heal the individual in community." And it's a really good way of being in community and healing as a community. So traditional foods and seasonal activities, so gathering, hunting. We have a lot of teachings among the different generations. Our elders are very highly valued among our people and very rare. The current life expectancy of a Native American is about 65 years of age. So if someone reaches an elder status, it's a very high level leadership role in the community. We also promote nutrition, so what we eat from the ground, being able to recognize what foods we eat, how they help us, how they heal us, kind of that farm-to-table approach you may be aware of. Also, wellness, our version of wellness, as far as our spirit, our level with their community, maintaining relationships, and community resilience. We could say we are still here very often. Despite all of the challenges that our people have faced, we are very resilient people and very proud people of who we are and our status here as among creator and the animals. Okay, so our current urban and rural perspectives. And we actually have an agreement with the United States to be able to provide certain things as part of our treaty agreements. So part of that is their health care. They have an obligation to provide health services. They do this under IHS or Indian Health Services, as well as the Urban Indian, which includes the Urban Indian, tribal, and programs from the Indian healthcare system. There are clinics outside of that that don't have contracts with IHS, but are specifically done by tribes to help their members or the surrounding community. So it's not just specific to IHS. We also have, that also kind of describes the increasing exercise of self-determination in healthcare. The tribe should be able to decide how they approach it, who does it, their hiring practices, and at what levels their goals are to heal their community are all determined by the tribe. There are persistent challenges, unfortunately, including what we mentioned earlier, underfunding, as well as workforce shortages, especially in those rural areas. It's hard to recruit and retain talent. And the pay scale levels don't keep up with the current outside of that system. So if hospitals have a new rule where they have to pay out a certain amount of money, for county hospitals, that may not apply to the IHS clinics. And so we'll lose people to those hospitals as well as, unfortunately, I've heard like McDonald's because they pay more. So it really creates a lot of health disparities because we need our people serving our people and our community in faces of recognize and trust, being able to be in those spaces of leadership to be able to really drive the health of their people. So what tribal engagement matters. So it's a really unique relationship with government to government because these are sovereign nations kind of housed within the United States. It also relates to tribal sovereignty, being able for the tribes to make certain decisions and being able to work with them in those decisions in a reciprocal relationship. Also, the importance of culturally appropriate healthcare, their version of healthcare that they recognize as being healing and serving their people, and also the historical context affecting trust and access. So it really speaks to the lack of trust and lack of access. So really being able to heal that and bridge that and make that part of the narrative moving forward and how to develop around that narrative, because it may not be something you're familiar with, but something that you may have to reach out and kind of learn for yourselves and be able to work with. Also, health disparities impacting tribal communities. So what those disparities are and how you can kind of best measure and meet them. It's not really guesswork. It's really a two-way conversation about what their needs are and how you can better meet those needs. So we also have Medi-Cal delivery among tribal and urban communities. So they do have Medi-Cal coverage. And part of that's having a relationship with managed care plans. So being able to coordinate with tribal health providers is really important, having these conversations and the federal protections of the members. So being able to know what their treaty rights are and what their needs are and how to meet those gaps in their needs and asks. So now Tara is going to go over the all plan letter and managed care tribal liaison role.
Thanks, Jessica. Again, my name is Tara. I am the tribal liaison for Kern Family Healthcare in collaboration with our local Urban Indian Healthcare Center, Bakersfield American Indian Health Project. So, as Jessica was explaining, we do face a lot of disparities due to geographical instances and historical instances as well. This is in healthcare, mental health, and other disparities that we face at a really high rate. And to counter this, the state of California came out with this all plan letter, the 24002 Managed Care Plan Tribal Liaison. Essentially, this role was created so that we could have a specific person that's addressing this specific population. Typically, you'll find your managed care tribal liaisons working with all of the Native Americans that are within their managed care plan. However, it's important to note that it's not isolated just to that. So I do encourage you to, reach out to your managed care plan and get in contact with your tribal liaison and how you can also help assist with tribal healthcare, tribes, or just learning about your local urban Indian healthcare centers as well. So essentially, a managed care plan tribal liaison, and it is a very complex role. All of us within the managed care plan are addressing this role differently. But essentially, it's the designated point of contact between the managed care plan and the tribal and urban Indian health programs in their county. Every managed care plan is required to have a managed care plan tribal liaison that is specific to help the well-being of Alaska Natives or American Indians within their health plans. This is often a population that gets very overlooked. So we do have an ongoing cycle of disparities that tend to be increasing. So this role is really to minimize that or make our best attempts to minimize that and to connect our Native Americans with our local urban Indian healthcare centers. Not all Alaska Natives or Native Americans are aware that there's even an urban Indian healthcare center within their area. So it's always important to be aware of that information. And it's always a good recommendation if you do come in contact with clients that identify as Native American to ask if they're aware of their local healthcare center because these healthcare centers are tailored specifically to the Indigenous population of enrolled members. And also, some urban Indian healthcare centers do provide care to those who are also part of unrecognized tribes. And I know Jessica touched on this a little bit. Unrecognized tribes, it just means that they don't have the same governmental stipulations that in recognized tribes would have. It doesn't make them any less of a Native American. It just means that they might not be able to receive the same benefits, and this is strictly due to history again, and who was making the choices and decisions when they were recognizing tribes. So they are still considered Alaska Native or Native American. So it's not a necessary point to ask if they are enrolled into a tribe. Strictly if someone identifies as Native American, they should be pointed to either a managed care plan tribal liaison or the urban Indian healthcare center. So that's how we're going to support communication and coordination and relationship building and just ensuring that we're considered when it comes to identifying as Native American. And we do have a spectrum of roles and responsibility. And this is a new role. This isn't a role that has always been a part of the managed care plan. So as you encounter managed care plan tribal liaisons, they might need to navigate some of your questions as well. They might need to learn about the areas that they're serving as well, since we are building this role from the ground up, but in collaboration with you that are in this call, something very good will come out of it. So it's really providing information to enrollment and disenrollment. We're coordinating care, so we're coordinating that access. So if you're referring a Native American to the managed care plan tribal liaison, then you can trust that tribal liaison to get them the correct access to care that they're needing. A very important thing to note when it comes to this role is that Native Americans, we do have certain healthcare needs that other populations might not have. This involves traditional healing practices, which Jessica's going to talk about at the end of this. It involves cultural care and also knowing the history of our people. As Native Americans, we do find it very respectful when people do know our history, or you at least know the lands of the natives that you are on. It's also providing assistance in accessing transportation. Transportation does remain a huge disparity in Indian country. This is due to many reasons. A lot of it is geography. And then we essentially provide the case management for these clients. So we're following their care coordination from when we hit that first point of contact all the way until they are in a steady flow with other departments that we may have referred them to. And it also includes provider relations and claims, payment assistance, and things like that. Also providing support in grievances. Sometimes we do have grievances that come through, and we can help our clients through this and understanding the issue, service navigation, and providing assistance with Medi-Cal. Medi-Cal can be tricky, especially since there are different stipulations that are required or not required of Native Americans, and they recently enacted this, whereas Native Americans don't necessarily need to meet the work requirement, um, and a few other stipulations like that. In your managed care plan, tribal liaison that you reach out to, or the Urban Indian Healthcare Center should have these answers for you as well. So this is very important to note when um, being or handling Native American clients. We also have a work group, and this is a work group that we, alongside Jessica Mosher, we meet with other managed care tribal liaisons and we talk about best practices, what's working for us, what are our challenges, how can we be better? And this has been really vital in this role. Some managed care tribal liaisons don't have a background in the Indigenous community as much as others, so we come collectively to learn. And we are very open when people are learning. I am also learning as well. There are over 500 federally recognized tribes within the United States and hundreds of tribes that are not recognized. And it's very important to note that every tribe practices different cultural tradition. So my cultural traditions in Alaska are vastly different from where I currently live in Bakersfield. And I've been living here for about 2 years, learning about the traditional practices of these lands, and that's so I can better understand the people that are living here. So even being Native American or Alaska Native, it doesn't automatically make you all-knowing of someone's tribe or culture. The important part is that you're learning in a respectful manner and that you're doing the best care coordination that you can have when encountering Native Americans. You won't always have tribal people of that land because in the current times, we kind of are spread around and we have this thing called intertribal, which is collectively what a lot of Native Americans have come to the point of, which is bringing us together, but we are all of different tribes or clans, and we accept each other as relatives, essentially. So we're really working, the managed care plan tribal liaison is will be working with the local urban Indian healthcare center to really ground them in this, making them feel community and feeling at home in case their family was displaced or they're displaced, and so they can have that cultural strength with them. Also to promote culturally responsive engagement and system navigation. So this can include giving presentations on cultural humility. It can include giving educational presentations on culture around that area. It's really all things that would involve American Indian or Alaska Native members. It would support coordination and integration of care across tribal, urban, or non-tribal health systems. So the managed care plan is a non-tribal health system. An urban Indian healthcare system just means that there is a healthcare center that is set in an urban setting. So I'm in Bakersfield, California. The Urban Indian Healthcare Center here is called the Urban Indian Healthcare Center because it is not on a tribally recognized land. And then you have tribal healthcare centers, which you can find on federated lands or reservations. Those are going to be less common because those are typically outside of main areas. But it is also important to be aware of those in your area as well. If you encounter, you're more likely to encounter people of these tribal lands than you are of not. So it's important to know of those tribal entities as well around you and learn about the reservations that your county resides around. And then it's aligning Indian health with path collaborative planning, implementation priorities, and providing insight to current challenges, experiences, and opportunities that we have for improvement. So it's definitely been trial and error, but overall, we've seen many benefits from this work group that's been occurring. And so we wanted to see how this aligns with the APL. And three main points that we came up with were collaborating with other MCP tribal liaisons, collaborating with our local tribal communities. This one is really helping individuals who are in this role learn how to collaborate with tribal communities and how to collaborate with the urban Indian healthcare centers because it can be hard developing that relationship. There is a large trust barrier that American Indians or Alaska Natives already initially have with healthcare. And this might not be all, but a larger amount do. And this is strictly due to history and the current alignment that we have with our government that is happening presently. So, if you do ever want to collaborate with your Urban Indian Healthcare Center and you aren't sure of how to go about it, you can always reach out. Um, but typically, it's just showing why you're wanting to reach out. If you have any Native American clients as well, you can always use that to bridge the gap and that you have well-being when it comes to this population. And overall, having knowledge and consideration of indigenous determinants of health. This is a big one because we, as Native Americans, do carry some of the largest statistics for determinants of health, largely across the board. But what I would recommend, you can educate yourself on the determinants of health that we have, like diabetes, or you could go into the mental health part as well with suicide. Native Americans hold the highest amount of suicide. But what I would recommend is really focusing on your county and what the main determinants of health for the Native Americans in that county are. That way you can better align yourself with what's currently going on in your county because you will find it probably not too different, but a little different depending on where you are located at. And this is how counties can support the American Indian and Alaska Native members. And I know I've spoken about this in the previous last slides as well. But it's identifying county contacts to connect with the tribal liaison. So anyone in your division, you're going to want to connect them with the managed care tribal liaison. So in DHCS, they'll deal with ICWA, which is the Indian Child Welfare Act. And this is an example. You might have a family advocate that's working with you, or you might have a foster care liaison. A big part of this role doesn't only include adults, it's also youth. And the foster care system does have a considerable high amount of foster youth that identify as American Indian and Alaska Natives. This is where ICWA steps in, which is an act to help protect Native American children that are in the system and to connect them with the best possible outcome, which is connecting them with Native American foster families. So, for an example, you can have that family advocate or the liaison or whatever the title is and connect them directly with the managed care tribal liaison. Those two would connect together. They would work on a care plan together. They would identify the needs of this youth and ultimately reach out to the Urban Indian Healthcare Center or their local tribe and create their care plan. So it's really a full circle moment and working in collaboration alongside your managed care plan tribal liaison. And this can be used in any setting. If you're in a behavioral health center, you can do it the same with adults with mental health needs as well. It's joining shared training on tribal engagement and cultural humility. DHCS does offer these trainings. There are also multiple other trainings that are available for cultural humility. I also personally do trainings on cultural humility, and not only specific to my county, but statewide in the state of California, I have cultural humility trainings that I've done as well. And if you are ever interested in learning more about that, you can feel free to reach out. I do love engaging in these conversations. They're really important, and there's never a question that doesn't matter or that is too complicated. And also supporting timely information and sharing to improve coordination. We don't want to wait on these issues. And it's very important to include or invite your managed care plan tribal liaison in county planning and outreach. So if you do have county meetings or any meetings that include well-beings of populations, of specific populations, we highly suggest that you invite and you welcome the managed care tribal liaison to invite to attend these meetings with you.
Thank you, Tara. So now we're going to cover California Advancing and Innovating Medi-Cal, otherwise known as CalAIM. So what is CalAIM? So it's really a multi-year transformation in Medi-Cal. It's entering its fifth year. The focus is whole person care, so the why, under the social drivers of health, why people are in these different situations, population health management and health equity, maintaining that and setting the levels to make sure that everyone has the same access to resources. So why does it matter for tribal communities? So it's an opportunity to improve access to services. Again, as we know, the IHS system we covered earlier is underfunded. Many people have, this is a high touch need among our people because we don't necessarily know how to navigate the healthcare system that as it changes or as these new opportunities become available. Also addressing those social drivers of health. And a lot of it has to do with enhanced care coordination because being able to get the one-on-one service really helps to fight those issues that we have as far as those our specialized health needs. And increasing collaboration between managed care plans and tribal and urban health providers. So it's really, again, a two-way conversation. We're going to want to have input in how our healthcare is done and by whom. And so really getting and being able to understand that relationship and build it is very important. So we kind of covered the tribal liaison role again within CalAIM, which is unique. Again, it's only been around for, a year and a half. So it's really about supporting tribal and urban Indian health provider engagement with these CalAIM incentives. So a lot of it's, as she mentioned, outreach with your Native American community and also the community-based organizations and being able to implement enhanced care management and community supports in a way that makes sense for the Native American community. Also helping tribal and urban healthcare providers understand those new program benefits. It's hard when you already kind of don't understand what's going on with healthcare, but all of a sudden you have new options. So now you are able to be helped in a way that you recognize and understand that you have access to these new benefits and services. Ensuring tribal and urban Indian perspectives inform implementation. So it's really about meeting people where they're at. We may not have the same access to, say, talent, those rural areas. So being able to make sure that they understand how to best implement it in the context of their work. Also facilitating collaboration with community-based organizations. Many of these kind of look like native names of nonprofits. A lot of them are in the context of SUD. So being able to recognize that and what their form of their approach to SUD is. Like we have programs like the Red Road. We have different ceremonies like the shedding of tears. So being able to recognize that and how to best work with that within the community. So I just got to take a minute to kind of let you know that you are all welcome to join us at the Indian Health Path Collaborative meeting. We meet the last Friday of every month. So our next meeting is March 27th from 2 to 3 p.m. And I don't really have a way, unfortunately, to post the registration link currently, but I will as soon as the meeting concludes. Okay, so traditional healers and natural helpers. This is a new option under CMS, really, Centers for Medicaid, Medi-Cal, under the federal system. So it's just started. We're entering year 2 of implementation. So it's a new option and a new billable option. We've been doing it, since time in memoriam, as we say. But we've always been fighting for compensation for these services. And before this, it usually happened under grant funding. But now that it's billable, it should be able to establish these traditional healer and natural helpers in actual employed roles within the clinical setting, and not really an as needed approach, so that there's more consistency and people can actually make a career out of it, that used to kind of just hope to be able to do this along with a full-time job. So there's a whole website dedicated to it on the DHS website called Traditional Healthcare Practices. There's also current program information, and FAQs are constantly updated, and they have different events about it. So there's an events page also on the site, as well as a link to just the general services for Medicare and Medicaid services. And this is the option here below for technical assistance. So it's traditional healing at dhcs.ca.gov. And on the next slide, we have the different providers of the technical assistance. So you go specifically to DHS for things like policy questions or billing and claims questions. It's a different process because it's under reimbursement. And so you have to submit reimbursement to the counties under the DMC ODS, part of the behavioral health arm of the county. And then, so learning how to do that for someone who's never done billing before, who's only done grant work, is very complicated. And a new thing that they need to be able to learn. So technical assistance is available through the California Consortium for Urban Indian Health, or SACUI. Also the California Rural Indian Health Board, also called CRIB, and Kaufman Associates are the 3 providers of technical assistance in this area. So we kind of wanted to know, has your county been engaged with traditional healers and natural health helper practices at all? Have you guys established any building? Anyone want to come off mute and kind of share what their experiences have been so far? Are they able to come off mute? Oh, yeah. So I'm guessing that this may be a new concept to this group, which is great. So we're all here to learn. Oh, we have a hand raised. Brittany?
Yes, so I'm from Sacramento County. I am the ICWA liaison for our DCFAS system. And so before we even, this has been an expansion of being able to access these types of services. We've had to utilize and connect our youth that are traditionally in foster care with traditional healers. Some of the challenges are that because we're more urban and a lot of our youth might be out of state or very, and so sometimes the traditional healers were not in the local area. And so we've had to navigate arranging not just their service that they're providing, but also the transportation built into the fee. So that has included, like a recent one was Navajo Nation. There was a healing practice that needed to be done with a youth that was expecting, that is very standard within their tribe. And so we had to navigate with the doctor with that. And so that's something that I think it's important that providers are aware of, is that it's not just the single service, but how you will have them get to them. And not only the service provider but the patient, too. That's one piece. And then I do know we've also being aware that providers do it in a community space sometimes. And so sometimes under Cal AIM, when we've tried to access using transportation underneath that, being aware that it might be at a non-medical facility that you are performing a practice, particularly in an outdoor space or a sacred space that's been identified. And so I think that's really important to highlight because we've had some, oh no, we're not, that's at this location, and really saying like, you kind of have to push back. And also knowing what is available for a particular population. Foster youth kids might have different access to different items and their parents versus other. So I think it's also very important to understand their cross systems because then you can strategize ways to cover that. So a great example is that we have enrichment funds that are pulled from the state. We figure out, okay, how can we use that under enrichment dollars if those continued? I hope they do. And also, we've utilized wraparound dollars if that youth is. So I really do say knowing what that youth, particularly in our system on foster care, can draw down is really critical to know. It's because it is collaborative of how you can approach it and what dollars can pay for which items for the service.
Uh, I love that. Very good highlighting the challenges and how you overcome them. I appreciate that. Andrew?
Good afternoon, everyone. I'm from Kern County, and actually, we're very blessed to work with Bakersfield American Indian Health Project already. So we've been very fortunate in our collaboration with them. And I think as we have connected more and really um, allowed our families to find what they need. I think that's the key is they find what they need. And I think part of that has been our BAIHP advocates and their MCP team connecting them to traditional healers and to other services that, fit in more with the culture and what they need, regardless of what tribe they're from. It's giving them that connection to their family, their values, the culture. And so, again, very blessed to work with BAIHP and with Tara herself. So, kudos to what they're doing and the work they're making throughout Kern and throughout the state. So, very, very glad.
Appreciate that. Anyone else want to highlight, maybe have questions about this, how to best interact with this in their county? So there is also a tool, if you don't know, as Tara mentioned earlier, who's in your area. DHCS has also developed a map where you can kind of put in your zip code and see who's a provider in your area as a starting point. They will, if they don't have it specifically, they'll probably know who to best reach out to. Anyone else have any experience? Maybe you guys have in your county you have different work groups among this, or different behavioral health groups that meet that focus in on different communities, including Native American, Alaska Native community. Okay. Tara, is there anything that you want to highlight?
Yeah, I'm curious if anyone in counties is facing difficulties with engaging in tribal, urban Indian health members. So I know this can be difficult a lot. Native Americans sometimes don't even identify themselves. Wendy, go ahead.
No, I just wanted to say this is so helpful because, me being first five, we actually have really wonderful relationship with the Riverside San Bernardino County Indian Health incorporated, and they are our county tribal McD, where they provide home visitation, and so they are in our collaborative. But this actually helps me to kind of extend, other than home visiting in the little space, what other health connectors that we kind of connect with, and to kind of do the whole health system for our families and littles. So this is very helpful. I just really appreciate you guys being here today. So thank you.
I would like to celebrate that the first five in Marin County actually has a Native American play group for 0 to 5. And that's been really helpful to the community. So props to first five.
Oh,
Kristen, go ahead.
I just have a question. I don't think you guys covered this. You may have. Are the managed care plans, is there like a requirement to reach out to community-based organizations that are serving our Native families in our communities to try and encourage them potentially to become, an ECM or a CS provider?
There's not a direct requirement for MCP tribal liaisons to do that because it is focused on the managed care plan and the development of the relationship with the urban Indian health care centers. So their primary objective, if they're not already contracted, is to get contracted with the urban Indian health care center.
Okay.
But what the tribal liaison should be doing as they expand beyond that relationship is to be including themselves in these county meetings. But that has to be done in collaboration as well with other organizations. But there's no direct requirement for them to do that. It is very helpful for them to be involved in community meetings. That way, people can understand the managed care plan tribal liaison can understand what their Native American populations are looking like in these different organizations, mental health, foster care, healthcare issues that they're facing. But there isn't a direct requirement, no.
Thank
There
you.
was, however, part of the gap fill analysis that each managed care plan was supposed to do at the beginning of CalAIM had a tribal engagement component. So how you're going to engage with tribes and contract with tribes. So that's available online on the DHCS's website. If you look up IPP gap fill analysis for managed care plans, it comes right up and it's listed by county and managed care plan. If you want to see what your managed care plan had planned as far as tribal engagement and collaboration with the local Native community. Joaquin?
Hi, going back to Tara's question about engaging American Indian clients, I'm not that familiar with the engagement numbers. I know that in the past, our county has referred them to our local tribal community SUD residential program. However, currently we're in the process of creating a partnership with our local tribal SUD residential program for men. And our county is a DMC ODS county, so I am not that familiar with it. I am familiar with DMC ODS residential regulations and that population, but not American Indian. So I'm looking forward to learning more about this particular target population.
Thank you. Yeah, and it's also important to acknowledge that not all organizations are going to have an identifier for Native Americans or
Hmm.
American Indians. So, pulling that data from your certain organizations and seeing if you even have that is vital
Hmm.
when gathering information. But yeah, it's a learning curve for everyone.
Yeah, so I'm looking forward to it.
Awesome. Yeah, we are too.
Heidi? Heidi, feel free to come off mute and ask your question. Okay. Okay, I'm going to next one. So any general questions that you guys have about the presentation today, feel free to uplift and bring up. I see Joaquin, did you have something else you want? Oh, there you go. Just
Sorry,
checking.
I forgot to take it down.
No worries. Hey, if you got any follow-up questions, we'd love to hear them.
I'll add that this role is so complex, and I know I wanted to provide a high-level overview in a short amount of time. Our work groups alone go an hour, and we usually are running out of time to provide all the information to our other tribal liaisons within the state. So it is ongoing. Your main priorities as county would really be engaging with your American Indian or Alaska Native clients and connecting them with the appropriate care, which is starting with your tribal liaison in your county and the urban Indian health care clinics around you. I'm going to put my name and my email in the chat so you'll have access to this to reach out at any time if you have any questions about your local tribal centers, the managed care plan tribal liaisons, or anything else. And we do have a question with Heidi in the chat. She said, who can I connect with to find out who the MCP liaison is for Riverside County? I believe we do have that contact actually. But connecting with your MCP liaisons would just be starting with contacting your managed care plan that you are contracted with or the managed care plan in your county. Heidi, if you do need more reference on this, feel free to email me. I did put it in the chat and we can collaborate on that and find the contact for you.
Yeah, it's by managed care plan. So I know IHP, that would be Jasmine. Oh my goodness, what's her last name? Morgan is the one for IHP. As far as that, I can't remember any of the other ones off the top of my head. I just know her because she's one of the few actually enrolled Native American tribal liaisons. So we all know each other. There's three or four, Tara?
Mm-hmm.
You get extra special service from the members of the community doing this work. I just put like Tara. Let's see.
Yeah.
Anyway,
It's difficult to fill these roles with Indigenous people, to say the least. So that's why I was noting earlier that we're all learning alongside each other, and a lot of us are at different levels of knowledge when it comes to Indigenous communities. And then Brittany asked if there was a list for tribal liaisons for our managed care plans. We do have one, and it looks like it was put into the chat. Thank you so much.
also, Brittany, I appreciate your comment about Sacramento County having a work group with the Sacramento Native American Health Center, focus on youth mental health collaboration, which includes DCFAS, behavioral health and Indian education with our school districts. That's a very good point. Yes, most school districts have an Indian education program. So it's a really good place to, they have different cultural events that can be attended by the community as well as the students. You could attend and possibly work with that group to be able to make sure that the students, part of CalAIM is that education setting are getting the services they need. I know that also if there's a Native American school near you, like there's in Riverside, I know IHP does specific research with those students because they're brought in without any knowledge of the area that they're in, because they're usually from anywhere in the United States, not just Riverside County. So making sure that understand the services that are available to them and enrolling in services has been a really beneficial to the community, and IHP has done that. So I appreciate them for that.
Yeah,
Anyone else?
I wanted to add for that collaboration for those to be aware of and think of. So like our local center, they have grants that they pull down or they're trying to address. So like right now it's substance, there can be a smoking cessation, and They do a lot of great research as to part of their grant writing and that they are focusing on this population. So they're a wonderful resource if you want to know as to current medical needs with the population and target. And it could also see how you can help support members within a healthcare plan being able to access the support that may be available for that. And I just wanted to identify that. And sometimes some of that grant is also additional training too, that they might have available to community members to learn more in different subject area that can also enhance that. So definitely recommend a collaboration or partnership that focuses on it, where how we can support each other, how we can help them meet their grant needs and target audience that they're trying to, and vice versa.
Excellent. Thank you for pointing that out. Anyone else have any resources they'd like to share that have worked for them? Okay, thank you again for putting the Tribal Liaison list in that. I believe that is the most recent copy, the October 2025. It's not, from what I understand, it could change because these positions are frequently assigned to different people as people filter in and out of, managed care. I know that partnership, they recently went through a transition where the new Tribal Liaison is Sunshine Jackson. So I know that she's new to that role. She's been in that role for a month now. So that's the partnership. If you're part of partnership, their new Tribal Liaison. That's the only update I can think of at the moment. Anyone else?
I just had a final comment, Jessica. I wanted to say, that I struggle quite a bit lately. I think more than ever before during the beginning of this administration. In the past 10 plus years, I've been learning a lot of history of the natives, in particular the Hispanics that are also share in the grief of the trauma. And so I can just imagine when you add alcohol to that situation, it just becomes a big challenge. So I'm hoping, like I said, I'm looking forward to working with our new partner in San Joaquin County to help the members that struggle. Because, like I said, I get triggered my own self, and like I said, I'm learning about my own history, my own culture, but also learning about the Native American Indians. It's difficult. It's very difficult.
So the definition is actually anyone prescribed to anyone living on Turtle Island. So that includes Canada, Mexico, it kind of trickles down that direction, as well as, Alaska. So actually my tribe is Pasco Yaqui. So we are a border tribe. So they drew a line border through like our living room. So one of our things we often say is we didn't cross the border crossed us.
Yep.
So, that's a whole another 2-hour discussion.
I know. The more I learn, it's like I never focused on. I was born in Mexico and raised here in the U.S. since age 7. I'm 61 now, and I just really never paid that much attention until recently, and it's just there's a lot to learn.
All right. Well, thank you all for your participation. I appreciate you and the important work that you're doing, and enjoy the rest of your day.
Thank you. Bye, everybody.
Yeah. Thanks, everyone. And also, just to let everyone know, the presentation and recording will be posted to our CBSI website. And if you could take a moment, if you could just for a quick 2 minutes, just provide feedback to us through our survey. The link is in the chat. And with that said, hope you all have a great day.
Thank you. Bye-bye.
Thanks, everyone.